Hello, wherever you are. My name is Nam Nguyen. I am a professor of the clinical surgery and the director of minimum invasive surgery at Keck USC School of Medicine and Children's Hospital, Los Angeles. On behalf of my committee co-chair, Bethany Slater, and the entire New Technology Committee, I would like to thank APSA for giving us their platform to provide educational material regarding the emerging technology in the hope to narrow the knowledge gaps among APSA members. In the next 50 minutes or so, we will discuss two very hot topics that are of great interest among the practicing pediatric surgeons. They are magnemosis and applications of ICG.
Hi, I'm Bethany Slater. I'm the co-chair for the New Technology Committee, and we're very excited to start this portion of the APSASode, and it's a discussion of magnets for esophageal atresia. The committee had picked two presentations for discussion in this portion of the APSASode, and actually both presentations will be by Dr. Oliver Munster from Munich, Germany. The first presentation is entitled An Experimental Study on Long-Term Outcomes After Magnetic Esophageal Compression Anastomosis in Piglets.
Hello, everyone, and thank you so much for the opportunity to present our study on long-term outcomes after magnetic esophageal compression anastomosis in piglets. These are Dr. Harrison's conflicts of interest. The other authors have none. Thoracoscopic esophageal atresia repair affords many advantages to the patients, but suturing a secure watertight anastomosis intracorporally is technically extremely demanding. Therefore, some have proposed magnets as an alternative to create the anastomosis, but this has been associated with a high stricture rate in the past. We therefore designed biradial magnets that produce a central zone of compression and allow the tissues in the periphery to heal. We have shown that these magnets do indeed create nice anastomoses 8 to 10 days after placement in piglets, but the long-term outcomes have not been described so far, and this is what the study is all about. In 8-week-old piglets weighing around 16 kilograms, we performed a bypass loop of the esophagus and placed the magnets in a side-to-side configuration. The magnets formed the anastomosis 8 to 11 days afterwards and passed with the stool. And at 2 weeks after placement of the magnets, we surgically closed the bypass loop so that the piglets would now have to feed through their newly created anastomosis. We fed the piglets and watched them carefully for 2 months. We particularly monitored their weight gain very carefully and sacrificed them after 2 months. We performed esophagoscopy and contrast esophagograms, explanted the esophagus, and looked at it histopathologically. Of 10 piglets that were included in the study, unfortunately, 4 died of pneumothorax due to dense adhesions between the lung and the chest wall at the second surgery. 6 survived, of which 2 showed that they had not closed a bypass loop completely. Interestingly, those 2 were the ones that had the highest weight gain, although none of the piglets showed any signs of dysphagia. On esophagoscopy, we saw a widely patent magnetic anastomosis, and in most piglets, a small dimple where the bypass loop had been. In the ones that I mentioned with the open bypass loop, we saw 2 lumens. This was confirmed on contrast studies where you see the bypass loop patent on the right side with the arrow marking it. Macroscopically, we saw widely open anastomoses, and microscopically, the magnetic compression anastomosis marked here in M was surrounded by intact epithelium, which we believe decreases the sclerosis rate and therefore the stenosis in the long term. In summary, our magnets produce a safe, resilient, functional, and long-term patent esophageal anastomosis in piglets. The complications we encountered were associated with the animal model, but not with the magnets per se. Therefore, we believe this method has potential to provide a simple, secure, and purely endoscopic means of esophageal atresia repair. And finally, we believe that the next appropriate step would be a carefully monitored clinical study in select patients. Thank you very much, and please feel free to contact me for any further questions. Thank you.
The next presentation is entitled The ABCs of Magnetic Esophageal Compression Anastomosis Using Spatially Designed Curved Magnets for Minimally Invasive Repair of Esophageal Atresia, also by Dr. Oliver Munster.
Hi, this is the first report of magnetic esophageal compression anastomosis using specially designed curved magnets for minimally invasive repair of esophageal atresia. These are our disclosures. Magnets have been used for esophageal atresia repair, but have been associated with high rate of strictures. We believe that this is due to the configuration of the magnets and designed new ones that are biradial in shape that produce a central area of compression and allow the tissues to heal in the periphery. These have been extensively studied in animals, and we are now ready to perform the first trials in humans. This report describes our experience in 3 patients and the outcomes of 1 year thereafter. All cases were reviewed by the ethics board as compassionate cases and approved. The first patients were premature. One of them had Down syndrome, and the third patient had complex cardiac disease. In the first step, we approximate the esophageal pouches thoracoscopically, as seen in this following video. In order to perform a thoracoscopic approximation of both pouches, an endoscope is placed in the upper pouch to allow better identification and dissection. We then turn our attention to the lower pouch, which also has an endoscope in place. It is dissected and mobilized until both pouches can be overlapped. The first stitch is placed using a sliding knot to approximate both pouches. Additional stitches bring the wall of both esophageal ends together so that they completely approximate. Once this has been accomplished, we give the tissues time to elongate and then place the magnets endoscopically for the anastomosis, as seen here. Esophageal approximation is confirmed by endoscopy. The first sequence shows the deployment of the lower esophageal magnet. Here it is seen passing through the esophageal hiatus into the lower esophageal pouch. It is slowly and carefully advanced until it reaches its destination. At the end of the pouch, it remains in place because it is attracted by the upper esophageal magnet so that the grasper and the endoscope can be removed. The next sequence shows placement of the upper esophageal magnet in a corresponding fashion. During the entire procedure, all maneuvers are guided by fluoroscopy, as seen here. 1 to 2 weeks later, an anastomosis is formed, and its patency is verified by esophagram. There were no intraoperative complications, but in our third full-term patient, the magnet separated on post-op day 1 due to the increased thickness of the tissue between them. The magnets were repositioned endoscopically, which went well. The anastomosis formed between 7 and 14 days, and all patients were watched for at least 1 year thereafter. During this time, they were gently dilated 4 to 5 times. At this time, all patients are feeding orally without any trouble, without any dysphagia or reflux. In conclusion, magnetic esophageal compression anastomosis using our specially curved magnets produces a secure functional anastomosis with no or very little morbidity. Some hurdles remain, particularly with the caliber difference between the esophagus and the magnets, and when there's a broad tissue gap between the lumina. We are currently designing a prospective study, and I hope to be telling you more about this next year. Please feel free to contact me for any questions. Thank you.
Thank you very much, Dr. Munster, for those great presentations. Our invited discussant today will be Dr. Irving Zamora from Vanderbilt.
All right, so today we have with us Dr. Oliver Munster from Germany, and he has some two exciting papers and presentations that we want to discuss and get his thoughts and expertise on mainly magnets and magnet anastomoses. So Oliver, let's talk about the pig study first. Obviously, this is something you've been working on for some time now, and the long-term effects now is sort of what we're trying to figure out. I know you've sort of demonstrated proof of concept and being able to do the magnets, but now we're trying to figure out how these piglets are doing long-term. So what did you find to be sort of the most important part you learned from this second set of experiments?
Right. Thanks, Irving. First of all, thank you so much for the opportunity to present and be here. So, we had shown that the magnets actually create the anastomosis, but the question was whether the pigs would be able to feed through it on the long term. So, you have to know that pigs generally go into puberty around 100 days, 120 days. So that's why we figured if we chose like 2 months of observation, it would be more like the entire prepubertal time.
Right.
So that made us choose 2 months for an observation. And the difficulty of this model, obviously, is because you have to do 2 thoracotomies. And as you know, pigs just create an awful lot of scar tissue adhesions. And going in the second time was really not easy. So we lost 4 pigs, unfortunately, but we had 6 pigs that survived to endpoint and then were sacrificed. And in 2 of those, we found that the bypass loop was not completely closed. So that's like a little bit like cheating, because they can eat actually through the anastomosis in the bypass loop. But in fact, in 4 pigs, they were closed. The bypass loop was closed. So we proved by that for this long time, at least for a pig in the in relation to the pig's puberty, they were able to gain weight, take in oral nutrition, and gain weight adequately for almost their entire pubertal life.
That's fantastic. Yeah, no, I know that the model is very unique. I mean, to be able to have that loop, which I think is fantastic. So as you think about, continuing to study this in the lab, what's the next challenge? What are we trying to answer? I know this is one big question is long-term, but what do you think as we sort of extrapolate this, obviously to human use, what can we learn from the piglet studies?
Yeah. So, the main question was, how long does this anastomosis remain open? Because in previous studies, as you know, magnets have actually created a lot of scar tissue and have needed to be dilated, the anastomosis after a magnet use. So, these magnets, because they're so uniquely shaped with the biradial configuration, that was our hope, that they would not form that much scar tissue, not stenose as much, and actually, be long-term patent. I think if you go on, I mean, the real challenges are, how do you deploy the magnets in humans? If you translate it to the human model, is it useful for not only, a side-to-side anastomosis, but an actual end-to-side anastomosis for type C atresia, because those are obviously the most patients that you will encounter. And, it's difficult to model that in a pig because, it's not the same. But perhaps with, some modifications, we can get there and then show that it's useful in what translates to a type C esophageal atresia in humans.
Yeah, that's to me, that's the most fascinating part to me is sort of how are we going to use this in the long term, and we'll get into that a little bit. But you mentioned something very interesting. I want to clarify. The magnets that you used for this study are specifically the Connect EA magnets, which are concave to convex, which are different than the existing, Cook Flourish magnets, which are convex to convex or concave to concave, sort of bullet-shaped anastomosis.
Right.
I think that's one of the biggest differences between these two devices. And so I just want to clarify that for the audience that, so when we think about the use of these magnets, when you compare the two, what do you see are the biggest differences between these two devices?
Right. And I mean, that was our big goal, right? So when we sacrificed the pigs, we looked at it histologically, and what we could show is that there is actually a nice layer of epithelium, of mucosa, that bridges the area of the anastomosis. And I think that's the key to having less stenosis. And I think, our hypothesis obviously is that the biconvex or concave convex shape sort of lets gives you the center area of necrosis, but also allows the mucosa to bridge. And so that's one of the things that we did, histological analyses, but we also did things like burst pressure tests. We looked at it under fluoro, and and it's a useful anastomosis, and I think that's the main outcome or the main message of the study.
Yeah, absolutely. Well, and that's a perfect segue, I think, to the next study, which is in the opportunity you've had to use I think you're up to 6 patients now, right?
Well, we are with yours, right? I mean, so you're part of this. So yeah, so I just did one in Munich just a month ago, and that kid turned out really well. So it's actually now four that we did here, and the 2 that you contributed. So we're on our way,
Yeah, no, I heard. I think so. When we think about sort of the ABC study, the different types that we've used them on so far, again, we're learning as we go, and how who best to use these magnets on. And I think one of the most important parts of from a design standpoint is that, and to clarify again, and differences in the devices, these magnets are specifically for patients where the 2 ends are one way or another already in apposition, right? That's very important because the way they're designed, they're meant to create an anastomosis, not to close a long gap, right?
Right.
So when we think about that now with our ABC and the 3 patients you've used, that I had the one complex patient I was able to use it on. What are we learning now? Our first several cases that we think is important for folks out there that are going to want to use these devices. From a technical standpoint, let's talk about that a little bit, because I think that's really important.
So we started with the type A, gross type A patient, and these are all compassionate care patients. So we had to talk to the ethics board individually. So you're absolutely right. I think that's I think the beauty of using the magnets is that you need to that you're separating the apposition or the tension part with the anastomosis part, because putting that together, doing an anastomosis under tension, as we all know, is really setting yourself up and the patient up for trouble, because an anastomosis just doesn't like tension. So the beauty of all this is you can get the ends together. We call it an approximation or an apposition. And then you wait, and then it's kind of this, whatever you want to call it, growth, induction, Fokker technique, where a tension induces growth. And I do believe that after, giving it a few weeks to sort of, stretch, grow, whatever you want to call it, then you can do the anastomosis, and the magnets can do the work. And putting in the magnets is super simple. I mean, you saw the tables. I mean, 25 minutes median operative time. It's like a real.
I slowed you down with my 38 minutes. Sorry about that.
Yeah, of course. Yeah, but
but you're average.
We also did it cross ocean, right? I mean,
Exactly.
It was like a transatlantic thing. So it's okay to take a little bit longer. But you know, it's really getting them ends together. You can do that thoracoscopically. That's, you know, you're not sewing an anastomosis, so you don't have to worry about leakage or anything like that. And it's also a very simple method. If you can technically manage to do a slip knot, then it's easy. Really, you put in 3-4 slip knots, you bring the ends together, and you wait. And you can do that in an hour. And then in another 25 minutes, you put in the magnets a few weeks later, and you get, you know, generally good results, I think, and like we've shown.
Yeah.
So that's essential. Now, if we, you know, we haven't, the type C kind of was not really a fresh type C, right? Because somebody else had already divided the fistula. So you have this special situation where you're really not, you know, it's not a fresh type C. I think the real issue is, how do you apply this principle to a type C? You know, what kind of clips do you use? How do you close the fistula? Do you divide it? Do you sew the ends together in the first round? Do you do in a type C, if you're a short gap, you might even not have you know, as much tension, and you can probably even do it all in one. At least in those cases where, you know, the upper pouch and the lower the fistula are so close together that you could probably put it in. The question is, how do you put it in? You know, do you do it? I don't know. We've been thinking about like putting the lower magnet in bronchoscopically, which, you know, is obviously a challenge, or do you do a gastrostomy? Then you would have the critique of actually doing an abdominal operation in a kid that otherwise would not get an abdominal operation.
Yeah, and I think that's the biggest thing right now. Most of the patients we've used it on, you know, have obviously you're committing them to a gastrostomy, and most have been appropriate for that. But as we continue to try to, you know, think about how do we use this and apply it to the most common cases, and truly, you know, replacing a thoracoscopic or hand-sewn anastomosis with a magnet at a first operation, right? That would gain the widest use of this, because what we're trying to demonstrate is that this anastomosis is as good or better than a hand-sewn or a thoracoscopic, you know, approach. So when I think about that, right, you clip if you're thoracoscopic and you clip the fistula, obviously you can't use a metal clip for obvious reason. But if you have that fistula open on the distal end, can you somehow place it, you know, into the distal pouch, close that, and then oppose them in the same operation? But then, you know, you run into the risk of, okay, well, now you have a freshly, you know, closed fistula that you have to make sure that it's not incorporated in your magnet repair. So that's really the case, in the question. You know, I know Dr. Harrison's been thinking about, and you guys have too. How do we apply this, you know, long term in these patients where you don't commit them to a gastrostomy?
And the other thing is, you know, it's only one case, I know that, but our case, and you know, I think all of us know that when we go in and we do, the fistula is usually kind of slender. You know how you have this typical, you know, champagne glass appearance. You know, the upper pouch is huge. You can put that in, you know, a magnet in, and the fact that we had difficulty having the magnet pass in the type C, I think, is kind of alarming. Maybe we need a smaller magnet in the distal, in the type C with the distal end, because the fistula is just more slender and it won't pass. You know, I mean, you know, we can't deduct anything from one case, but these are just things that we, you know, should have in the back of our mind when we move forward with this.
For sure. And I know that they're working on different sizes, some smaller, some bigger. You know, in my patient, you know, we decided to use it because he was a larger patient already. He was at, you know, older than a year by the time we decided to do it. So I think it's a matter of applying it to the right patient population currently. But as we continue to, you know, I've already gotten, you know, messages and phone calls. Hey, I have a patient who's, you know, who I think would be good for this. Can you help out? And so as I think about that, you know, we're trying to apply more widely, people are becoming more interested. And so how do we, which brings me to, you know, the next point, which is the new delivery system. You mentioned that earlier, which was just presented at IPAG. Which is exciting. You know, they're working on kind of the new delivery system, which is very slick, you know, and I think it's going to make the technical part of it even easier. It's already relatively easy, as you mentioned, but I think, you know, having the the device is going to be nice to be able to control, to toggle, a posy
Right.
and release it. I thought that's
Right.
going to be really nice.
Absolutely.
Well, thank you very much, Dr. Zamora and Munster, for a great discussion. And I just wanted to clarify one quick thing too, in discussion about using magnets for esophageal atresia. I really would love to applaud you on having such a robust animal model and then taking it to humans, really great studies. And then Dr. Zamora had mentioned the Flourish device, which is a catheter-based magnet, which is actually used for patients with esophageal atresia that either don't have a fistula or repaired fistula and have an esophageal gap of less than 4 centimeters. So that magnetic device is actually meant to attract the two ends and then create the anastomosis. But as was mentioned, there are some differences amongst the two devices, particularly in the way of the convex and the concave magnets. And the Flourish device also comes down to a 10 French coupling mechanism. So there are certainly some differences and different indications for the patient population, but these are really great devices for specific patient indications for using of both of them.
For sure. And the Flourish device, as far as I understand, ultimately you have to go and retrieve the magnets versus.
No, it's a catheter-based system. So once the magnets have coupled, you can remove them through the catheter-based aspect of it.
Well, that's what I mean is you have to there's one more procedure you have to go in and remove them versus the Connect-EA where they basically just pass on their own and that's how they're designed to do, I guess.
Correct. Yeah, but it's not an operative procedure because you can just kind of cut one side, or depending on how it comes out, you can just pull them out. But they're both really interesting, and I'm sure we'll see more of both of these devices. And thank you guys again for a really interesting discussion.
Thank you.
Thanks, Bethany.
Good evening. Welcome to the APSASode session of the APSA Innovation Committee, Fluorescence Image-Guided Surgery for Pediatric Surgeons. The authors have no disclosures. We're going to talk today, I'm going to talk about introduction and background briefly. Brian Gulak from Chicago is going to talk about biliary procedures, intestinal viability. Bradley Segura from Minneapolis about oncological applications. I'm going to discuss the ureter briefly. And then Samir Pandya from Dallas is going to talk about platform technology and capital investment. And then we have a quick session with questions and discussions. Fluorescence guided surgery is an exciting medical imaging technique used to detect fluorescently labeled structures in a dynamic fashion during surgery. Camera systems that detect the infrared light is not visible to the human eye can provide information about anatomy and tissue viability to the surgeon through real-time visualization. ICG is a safe water-soluble compound that received FDA approval in the 50s, long time ago. Despite its bright green color of the reagent to the human eye, the contrast agent is based on a robust fluorescence in the near range. Applications for pediatric surgeons are emerging, and it can be used for arteriograms, tissue perfusion, such as intestine before anastomosis or soft tissue pedicles during plastic surgery. And it gets exclusively cleared by the liver and the bile duct and can be used for cholangiography. Intradermally administered, ICG gets protein bound and then is confined to clearance via the lymphatic system. That facilitates sentinel lymph node detection and biopsy. There's an international society for fluorescence guided surgery. They have webinars and education, billing guides, also dosing guides on their webpage. Membership is actually free. And you see some images here from the bile duct in the center and from a case of cystic biliary atresia on the right, where I used it for cholangiogram and then to facilitate the Kasai procedure. Indocyanine green is the only near fluorescent agent currently approved, and it's a water-soluble tricarbocyanin of 776 Dalton that rapidly binds to plasma protein in the body. It was first approved in 1955 by Kodak Research Laboratories, and received FDA approval for retinal angiography in 1959, and since then has been used for that, as well as cardiac output, as well as hepatic function measurements. After IV application, it remains largely protein bound in the endovascular space and then is exclusively cleared by the liver. And its half-life in the vascular system is about 3 minutes, so it can be used repeatedly. From the vasculature, it undergoes uptake by the hepatocytes, and then hepatic clearance and can be detected within the bile within minutes, and then peaks over the course of hours and continues for over a day after typical dosing. Towards its history, it has maintained a high safety index with favorable side effect profile. It does contain sodium iodine, and there are rare reports about anaphylaxis, about 1 to 10,000 as the manufacturer says. And then iodine uptake studies should not be performed for 1 week following use. So I invite you now for our session and for the following talks. Thank you.
So I'm here to talk about biliary procedures. Biliary procedures are one of the most common utilizations of ICG technology, frequently used during cholecystectomy, especially in the adult population. There's been a lot of data in the use of ICG for these procedures in the adult population, and most of them have demonstrated similar outcomes for intraoperative cholangiogram for their ability to identify the biliary structures. However, it should be noted that they cannot be used to identify biliary stones. Just as with conventional intraoperative cholangiograms, there is debate over whether or not it has any real benefit in reducing common bile duct injuries. Some reports have identified quicker cystic duct identification and a reduction in operative time. And once again, most of this data comes from the adult population. There's a few studies in the pediatric population. This is one by Calabro et al., where they looked at 31 patients who underwent a laparoscopic cholecystectomy with the use of ICG. They gave 2.5 milligrams and 1 ml of saline of ICG just before their trocar placement. And they identified very good cystic duct to common bile duct junction visualization, and they had no complications. And over here, we have a picture that they supplied in their manuscript. They demonstrated a reduction in operative time as well, from 121 minutes with no ICG to 105 minutes with ICG, and compared this to 164 minutes when intraoperative cholangiogram was involved, and only a very small jump in the cost of the overall procedure. This is another study talking about the use of ICG for Kasai procedures, which is another developing area in the literature. This is Yanagi et al., which compared 10 infants for which they used ICG during the Kasai procedure to 35 historical controls, and they gave 0.5 mg per kg of ICG. This is a figure from their paper, which demonstrates the ICG at the porta, as well as their ability to suck up some of the hilar exudate in a syringe, and again, look at it under the camera. And again, as well, the stump of the resected fibrous corn. When they compared their 10 patients that used ICG for the Kasai procedure to the 35 patients in their control group, they found that the ratio of post-operative normalization of hyperbilirubinemia was 100% in the experimental group, as compared to only 65% in their historical control group. Another place that ICG has seen a lot of use, especially in the adult population, is intestinal viability. In adults, this is often used for bowel anastomoses, but it's also used in plastic surgery for flaps. And one of my colleagues will be talking a little bit more about this further down in the talk. In adult studies, it has demonstrated that ICG can lead to changes in the site of anastomosis. However, no studies to date have shown a benefit in reducing the rate of anastomotic leak. And again, the reported dose in the pediatric population is about 0.05 to 0.1 mg per kg in infants and about 5 milligrams in children. The Mark Levitt's group did publish this one paper here on 13 children they used ICG fluorescence angiography for complicated colorectal surgery, including cloacal reconstruction, Hirschsprung's disease, and anorectal malformation repairs. And they found that almost a third of the time it changed their operative case, mostly leading to a higher transection point. And they had no complications from the ICG injection. So in conclusion, ICG fluorescence angiography has seen heavy use in the adult population for biliary procedures and tissue viability, but data in pediatrics is lacking. But the data that is currently available shows that it appears to be very safe, and it may lead to some benefits, including quicker identification of the cystic duct, possibly better Kasai procedure, as well as better bowel anastomoses. Thank you.
Hello, I'm Brad Segura from the University of Minnesota, and today I'll be sharing on the relative applications on the oncologic front for fluorescence-guided surgery. Let's start with the case first. We have a 16-year-old female who presented with a large breast mass to clinic. Her workup was pretty extensive, included imaging and core needle biopsies that couldn't rule out the possibility of a malignancy, but ultimately proved to be a giant hamartoma. We want to talk about the utilization of our technology here today for a case like this. So once the large tumor was safely resected, we're faced with the challenge of dealing with the reconstruction. So on the left, we have the tumor specimen. On the right, we have a large defect that's left behind, and we have to contend with the issues of perfusion. So for this, I enlisted the help of one of my plastic surgery colleagues who introduced me to this neat technology. Relative old school approach here, we're transilluminating to look at the flap to determine what's viable, what's not viable. There has to be a better way. So with Spy to the rescue, this is an introduction to the equipment that we utilize for our case. There's the monitor, very mobile. And on the screen here, you have left and right images. On the left, a black and white image essentially demonstrates the area of malperfusion that we want to look at. And these are relative perfusion units that we use to calculate the areas that are potentially concerning. The fluorescent image on the right depicts these very nicely. This is our incision from the resection. This area is a little bit worrisome to us, and as you'll see on the next screen, we've highlighted this by pen, and essentially we were reassured in the end by what we had by way of numeric assessment, and the child ultimately did very well with the resection and the reconstruction without any further removal of tissue. So with regards to tissue perfusion, it really was the plastic surgeons who employed this modality pretty early on. It's been used since the early 2000s to look at skin flap viability. The Spatially system is no longer new, but at the time was developed to quantify tissue perfusion during operations. This is generally a task that was left to intraoperative decision-making and judgment of the surgeon, which can be difficult with such subjectivity. It was designed to help the surgeon identify incisions and geometry of the skin flaps to optimize vascular flow, and it provided real-time objective information regarding which regions would be the best, and therefore at lowest risk of having wound complications. On the oncologic front, as you've learned today, most of what we're trying to apply to our field has been based on work in adults. So ICGA was developed for the treatment and detection of cancer very early on in its utilization, specifically in the realm of breast cancer. Using the SPY Elite system, surgeons have been performing sentinel lymph node biopsies, and they report comparable rates of detection when compared with lymphoserum blue and technetium 99. A recent meta-analysis demonstrates that ICG fluorescence as a technique ranked first in terms of detection, had the lowest rates of false negatives compared with other techniques, and it provided the main advantage of allowing you to determine an accurate placement of your skin incision for the resection, mainly because it provides close identification of the lymphatics. Going beyond this, in the realm of therapeutics, a recent report showed that you can construct targeted nanobubbles, actually called TNBs, with ICG, and they can be used in this paper here for in vitro multimodal imaging to assess the mechanism and efficacy of breast cancer cell growth. It's novel in design and concept and may be helpful for the treatment of cancer. This is a report that came out several years ago saying it's not a novel idea, but demonstrates again that we can use ICG for identifying solid tumors and their metastases, and ultimately in a therapeutic degree for destruction of malignant tissue. Other applications include management of colon cancer, pancreatic cancer, thyroid issues, neurosurgical problems. The list is quite generous. But for this audience, most importantly, on the pediatric front, this modality can be used for, while somewhat experimental in nature, it's promising for identifying tumor margins, locating metastases, looking at sentinel lymph node biopsies, protecting the structures that you're trying to work around, and also for facilitating reconstruction as we showed today. Some of the potential roles include pulmonary metastectomy, chest wall metastectomy, partial hepatectomy for hepatoblastoma, rhabdomyosarcoma dissections for sentinel lymph node biopsies, and also retroperitoneal lymph node dissections and sampling. And there will probably be many others, with the sky being the limit. Thank you for your time.
So visualization of the ureter for fluorescence image guided surgery. Ureteral injury is a serious intraoperative complication and the reported incidence above 1% of surgeries. Most injuries, unfortunately, are only detected after the operation, leading to severe complications such as sepsis, fistulas, renal failure, potentially loss of the kidney. Stents are controversial, and there was a recent NESCOP study of 40,000 adults, 1,800 stents placed, and it showed there was a longer operative time, about 44 minutes, but there was no difference in morbidity and mortality between the stent group and the non-stent group. So in surgery, as we all know, identification of the ureter is paramount, especially in surgeries on the field, and it can be more challenging during laparoscopic surgery. And ICG offers a real-time identification of the ureter during surgery, especially for minimally invasive cases such as laparoscopic or robotic. And indication for us include masses in the retroperitoneum or the pelvis, colorectal surgery, redo operations, obesity, and others. The technique is very straightforward. The patient is in the lithotomy position. The urologist or yourself performs cystoscopy and places a 5 French open-tip ureteral catheter under fluoroscopic guidance, usually with the help of contrast. And the tip is placed before the level of the renal pelvis about. And then ICG is injected and the catheter is clamped for the duration of the operation and then removed after the case. And the dosing guideline of the ISFGS, they say 2.5 milligram per milliliter. However, different authors have used different amounts, especially from 2 to 10 milliliters, depending on the size of the ureter and the patient, probably. This is a 6-year-old patient I had recently with a retroperitoneal mass, which felt actually somewhat mobile, was detected by physical exam, and the ureter was not visible on the CT scan. And we chose to put a ureteral catheter in. You see the image on the right, fluoroscopic image with contrast, and the ureter was displaced by this mass and potentially at risk during the surgery, laparoscopic surgery. And we injected 4 cc's of ICG, and unfortunately, the images of the video were lost at the end of the case, and the only image left is the one on the right upper, where you see the mass then finally being removed. So I took some images from the literature which show the ureter visible in the case, and this was really, really nice in this case and helped identifying the ureter, preserving the ureter, resecting this mass out from this ureter. So as a conclusion, fluorescence-guided detection of the ureter using ICG is safe, ready for use, and there's no systemic exposure. The disadvantage, obviously, you have to place a catheter in the ureter, and it's really cool in the surgery to flip the switch and see the ureter at any time you want in real time. Thank you very much.
Thanks, guys. We've heard a lot about how we can use the fluorescent image-guided surgery in our practice, and I'm here to talk about the technology behind it and how we can implement it into our individual systems. My name is Samir Pandya, and I'm in Dallas. So Stefano already mentioned our disclosures. I have an additional disclaimer that the information presented here is based on personal research and observation, but please reach out to your vendors for additional product information. So we know that this technology can be utilized in open, endoscopic, and robotic approaches. In order to do so, there's mainly 2 things that we require. 1, the indocyanine green dye, and 2, the optical equipment. So let's talk about the dye. So the dye comes in a vial that needs to be diluted with 10 cc's of sterile water. Each vial has about 25 milligrams of ICG green. You can get the dye in its generic form, and it's typically available in your pharmacy. And that's an off-label use, and it costs about $65. However, you can get a pre-made packet of the dye, which is manufactured by Stryker, and that's they have gone the extra step of getting FDA approval for this, and that costs about $100. Both things are identical. With regards to open surgery, I thought it'd be good for us to compare the 2 main vendors that most of our facilities have and most of us use, and that's namely Storz and Stryker. And we'll start with the devices. With regards to Storz, they don't have a special handheld device as opposed to Stryker has a handheld device that is separate from their endoscopic solution. So how you would do it with the Storz system is you would use the regular camera head that you have, and you would end up using a VTOM, which is the exoscope that they carry. What differentiates the two vendors and their technology is that from a storage standpoint, they use dual 4K chips. That means there's a chip that's focused on the ICG green, and there's a chip that's focused on the white light. Whereas in the Stryker system, they use a laser technology, and that's how they process the image. From a monitor standpoint, Storz requires that you just use your existing 4K monitor, whereas from a Stryker standpoint, for the open platform, you'll have to use a video processor illuminator. In terms of the modes of operation, they both are very similar with a monochromatic view, a blue-green view, and a reddish view. One thing that differentiates the two is intensity mapping in the Storz platform. So here's a video on what it looks like, what the different modes look like. And so you'll see this to your contrast mode. And you see the white light, the way the white enhances all your blood vessels. It's pretty nice to assess for perfusion. And then next you'll see that it'll go to the green overlay mode. And usually what they recommend is that you start off with that contrast mode in the beginning and then move on to this green mode. And then finally, this is the CSF mode in which the blues are the background and the reds are accentuated in the foreground to give you the different views. So this is what it all looks like from a Storz standpoint. This is your, I've shown here a separate monitor, but you can plug into any monitor that you have on your boom. You would need a special camera, which has ICG technology. The way you can notice that on in the room is it's a bluish camera, special light, and then here's your processing unit. And then from a Stryker standpoint, this is the handheld device that can be covered with a sterile sleeve. And then this is the tower in which you'd have your video processing illuminator. From an endoscopic surgery standpoint, the main differentiators, I mean, they both have 4K cameras. The main differentiator is that from a lenses standpoint, Storz has, as we know, the 4mm lenses, the 5mm lenses, and now they have introduced 3-dimensional lenses as well, which will be available in 4mm diameter. The rest of the things are all the same as mentioned earlier. So here's a video of the Storz endoscopic solution for ICG green. Yes. We've already seen still images in the previous talks, and so here's tissue perfusion from colon surgery. And then this I thought was really cool is Sentinel lymph node biopsy in uterine cancer that they've used in adults. And you can see how the lymph nodes really get accentuated with this. I looked into where they had to inject for this lymph node mapping, and it was actually directly into the tissue. But I'm sure that we can find some way of helping our surgeons figure out the lymph nodes for our applications as well. ICG green is also used in robotic surgery. This is they call it Firefly, and this is a representation of that from Intuitive. And then the main issue with this is we all know that we are now transitioning to the new XI platform. What we need to know is that the XI platform has this as a standard feature, and it is already integrated into the system. So you don't have to have any separate upgrade. It does have a new sensitive Firefly mode in which it will allow for significant image enhancement. So in summary, the solutions are available for all surgical approaches. Modular solutions are offered by some vendors, and the systems can integrate into your existing 4K or 3D imaging. Pricing that obviously we all know will depend on your individual hospital contracts. Thank you.
Well, I'd really like to thank the panel for a really great and comprehensive discussion about ICG. Are there any questions from the audience regarding ICG that this panel can answer? While we're waiting for anyone to type any questions in the chat, I'll just start off to the panel here. If there was someone who was just starting to try to use ICG, what type of procedure would you recommend, and what's the best way to get started?
I mean, maybe I can pick this up. I mean, one of the easiest is for the lab choles, obviously. You know, it's a common procedure for us, and the only caveat on this is the timing of the injection, because ideally you do give it 2 hours before ballpark. And if the patient is an outpatient, they get an IV usually in the OR or just before the OR. So you're always going to be a little bit late on the timing, but it still can be helpful to identify the anatomy and of the bile duct, the common bile duct, the cystic duct. And it's pretty straightforward. There's not really a downside of doing it. I think that's a good procedure to start where you actually have some volume on it.
Yeah, and I agree. I think that it's really easy to get started. I mean, you just contact the reps and they usually will come and help you figure out the right dosing, although obviously our APSA toolkit that we have published online to help people get started is a great place to look it up. I'm not sure if everyone, if we can put that link on the chat for everyone to see. But the other one that's really good is anytime you're doing an anastomosis. Ben Zendejas mentioned esophageal anastomoses. I've used them a lot now for bowel anastomoses. I used one the other day for a laparoscopic assisted anorectoplasty. You really can just give it a try. It's a very low risk drug to give. The camera is very easy to figure out, and start using it before you need it. And that way, when you need it, you know what to do.
Great. Thanks so much.
I'll say that I'm still figuring out the optimal dosing and timing. Like I keep on experimenting with different things, and so I think I agree with what Stefan and Brian are saying, that the lab chole is the perfect one, and then you just try and figure out where the optimal timing and dosing is.
There is another question from Nathan Novotny. He's asking if you can directly inject it into the gallbladder. There are some reports actually out there, and he personally has not done it. I must say I've done it once. I usually find the IV approach sufficient. I must say, if you're in doubt or your timing is maybe off and you really need it quickly, or you haven't given it pre-op, that is certainly an option, that you insert a small catheter into the gallbladder, for example, a choleangiogram catheter, and inject it directly into the gallbladder to see the bowel system. I think that's a viable option.
And similarly, on that note, Irving had asked, do you think that ICG should be used for every lap chole or biliary operation, or more selectively?
I personally think it should be used for any, because there's no downside. You become more familiar and it can reassure you of the anatomy. I mean, there's still a good amount of complications in lap choles described, or I've seen it in our center, where people don't use it, and it can only help from my perspective. The complications are minimal.
So
yeah, I think the data out there does not show
by
that.
way of,
Sorry, go for it, Dr. Segura.
no, it's okay, Brian, finish up.
I was going to say again, just like I said before, you don't want to be trying to use it for the first time when you suddenly need it. So you may not need it for every single gallbladder, but using it when you have good elective cases and you have the time to plan for it, so that you're ready when you really need it, when you end up with that hot gallbladder and you can't figure out what's going on, is a safe bet.
There is another question we just see on
That's
the
great,
chat.
Brian.
Oh, I'm sorry.
Well, sure. I was just going to add along those lines that my representation of the plastic surgery approaches was something they can use in real time. They inject and we look at the flap shortly thereafter. I think that's really what Nathan's talking about, even with volvulus, atresia, perfusion. I was going to actually put you on the spot, Stefan, because one thing that you taught me through all this was just discuss with us, if you don't mind, the timing when you do your atresia cases. I like what you're doing with laparoscopic approach and assessment, but you're injecting a bit earlier. Maybe that was you, Samir. Tell us when you guys have to inject when you're going to do a biliary atresia case.
I mean, you're talking about biliary atresia, in this setting, you have to inject it much earlier, the day before, or sometimes even 2 days before. I usually use the day before, which is a good timing. I've done it essentially just before the procedure because it was forgotten. And even there, it was helpful. But ideally, you give it a little bit earlier. It does stick around for quite a while. Obviously, in the biliary atresia case, it doesn't drain into the bowel system but it can be helpful for laparoscopic cholangiogram in that setting. Or if you have a patient with allergils, it can help you identify. And then also for the dissection of the cone, and even for drainage of bile into a little gel foam while you do your Roux-en-Y. And you can look at the fluorescence you have in that gel foam after an hour. There may be some predictive value to that. We are not that far for this, but that is certainly an option you can use, ideally a day before. I wanted to pick up some of the questions on the chat.
I think that's a great idea. I can't wait to try it.
They're coming in kind of faster now, and they're talking about bowel anastomosis and when to use it and about the timing of injection. And Irving Zamora is asking this question, and it's very useful for looking at viability of bowel, but this is the vascular phase. So this is the first 3 minutes. So you inject it in the operating room. That's different than the bile system. And then you see the vascularity of the bowel or structures within the first 3 minutes, and then it slowly goes away. So the half-life is essentially close to 3 minutes for the vascular phase, and then it accumulates in the liver afterwards. So if you want to look at viability, you have to inject it right away. And you can repeat it, obviously, sometime later in your procedure. And you can change, obviously, before anastomosis, resect a little bit more if you feel it's not well perfused. One downside of the current systems is you can't quantify it. There's no number which tells you this is 100%, this is 50%. And my understanding is the companies are working on that. That's kind of the next generation where they're actually going to give you a number you can even go by.
And have you had experiences where you've redone an anastomosis based on the findings of your ICG?
Not redone, but resected a little bit more before doing the anastomosis.
And I quoted a paper from Levitt, Dr. Levitt's group as well, where they found that a number of times they changed the level of their anastomosis. But I have resected back a little bit of tissue on an esophageal anastomosis and as well as on a bowel anastomosis because it wasn't as perked up. But Dr. Zendejas mentioned in the chat as well, there is new quantification software that's coming out that will be available soon. There's already available with the open technology, as far as I know, but not with the laparoscopic technology, but that's coming soon.
Very cool.
Yes, Dr.
Well, any
Levitt,
last closing comments then from the panel?
who wants to give
Okay, well, then last question here from Nathan. Has anyone used the NIRS without ICG for parathyroid identification or others?
That's discussed in literature. I haven't seen that yet, haven't done it yet, but you're right, that is something people are talking about more and more. I think what's going to be cool is the future of oncology. If you can use it for targeted therapy, that's pretty slick. So the basic scientists need to help figure that one out.
Yeah. And I agree with that entirely. My closing, I've already said it a few times, I think, but there's the easy stuff, gallbladders, bowel anastomoses, we all do. Moving into the complicated things, lymph node resections, and oncology applications. And I think that using it for the easy ones first, getting a feel for it, you'll find that it's a lot easier than you think it would be to make this jump. And then starting to move into the harder things where timing really matters and injections matter as you get more and more used to it. I think you'll be pleasantly surprised with technology. And there was a comment on here that's mentioned that in the future maybe used as a medical legal when it becomes more and more common, that it may become medical legal if you didn't use it and had a complication. And so long before that occurs, you definitely want to get comfortable with it.
I mean, as a closing comment, I think it's just the beginning of the trend, essentially what he was just saying. The technology is going to develop further. And, especially in the pediatric world, it hasn't been around very much for a broad spectrum of, applications. I mean, it's a sexy concept, fluorescence guided surgery. It sounds good, obviously. And maybe it can guide your, identifying anatomy, vessels, which are just an overlay picture, essentially in your laparoscopic image in the future, in addition to quantification, before you do any connections or so.
Great. Well, thank you again to the panelists, and thank you very much to all the members who are listening and participating. This was a great session, and I also really look forward to seeing everyone live at APSA next year. Thanks again.
Bye.
Bye.